But now this is what we don't like to see, complications, but we must know how to manage it. And we do have complications, even though, you know, in the last years we have seen the improvement in all the implant designs, in the techniques. Some complications can be little complications, some can be very bad complications. The truth is that they go in between 13.5 to 54% of incidence. So some of them are due to technique failure and no knowledge of the problem, like in this case that obviously we know that something was wrong in the position of the talus. So, but what is the literature saying and what is the results that we know? There is nothing consistent, but we have intraoperative complications. Those are post-operative complications, wound healing, deep thrombosis like them, and late complications that maybe those are the ones that we can see in a data of 15 years or 20 years of evolution. And sometimes we don't see these results in other groups because they don't make this database. So that's important to face them. And the most important thing is this: 76 to 94% of these can be managed by retaining the prosthesis. And that is something that gives us faith in what we are doing. So this is another point, and Beat already mentioned it, about what is in a fixed bearing. The most common is the septic loosening 38, and in the mobile bearing is exactly the instability that gave us the thinking about how to solve it with another solution. So intraoperative complications are sometimes based off the bad planning and the bad knowledge of our patients, knowledge of the pathology, of the biomechanics, and it takes time for us. It was for me also a learning process. It's not only to put all the prostheses. We see here, of course, it's a technical error. It's not a failure of the insert, it's just a failure. In these kind of cases, whatever is the moment, you have to face it, we have to open, we have to make a revision and change it and correct our position. So what happened also with the intraoperative fractures? They are not so unusual now. First of all, we have to keep calm. The first one I saw, I have to tell you, I was like, oh, what I did, my God, somebody's gonna kill me, but no. Then you learn that you have to keep calm and see, just fix it because it works like it is. And if you see, I know he's gonna get mad, but maybe we can see that that is maybe a fracture that is made by the nature because something was straining there. And it is somehow what we see afterwards, the necessity of release the forces by a flip osteotomy. You know, so that makes sense also in the evolution of the nature intraoperatively. We have a wound healing process. When they are superficial, we have many solutions, just clean it, debridement, antibiotics, and even we can use these vacuums, these blood things that we know now. But what about if it is a deep one? We can see it a little late in the 8 weeks, or in this case, in the 18 days. We have to react. Sadly, we have to do something because it's going really inside and nothing is going to be well with this. We have to open it, we have to take it out, and then we have many possibilities. We have 3 of these options. 1-stage revision to TAR, 2-stage revision to TAR, 2-stage revision to fusion. Nobody wants to end in the third one, but it's a possibility and we must know it. We usually do the second one, and how we do it? Normally in a 2-stage. So we have to clean all as a normal debridement. We clean it, but we do use a spacer with cement and antibiotics, and we try to make it as our prosthesis and as a sculpture there. We keep it, yeah, that's why I love to make this like a sculpture of ours. So we take the time, and when everything is going well, we can make the revision. And of course, you have to face the problem, and maybe you will need a fusion, or maybe you will need even something more. But also it can happen a post-operative fracture. This is not so frequent, and this is the case, for example, of a fracture in an accident, automobile accident. So it happened. We have to face it. If the components are okay, we leave it. If they are not, we have to take them out. But we have to treat basically this as a normal fracture. And so fix it. And it can happen also fracture by stress. What we do here, we see that they were checking at the fracture. Of course, there is a problem here. And so the surgeon said, well, let's make the solution. We fix it. But the cause of the stress fracture is still there. It's not going to work. So it's just a matter of time that it will come back with a worse situation. So in that moment, we have, again, to just think about the biomechanics. We have to think what is going on. We have to underline the cause and then make a revision of this and change the prosthesis. So we have late complications, and they come after long-term evolution or short-term evolution. So there is a problem given by the instability. And you see, I have learned it so nicely with the professor in the school, how important the vectors of the heel cord. When you see this, you have to face it. You have to analyze what happened. The pull, it's not centralized. So it's gonna fail. And this is not a failure of the implant, it's a failure of the planning, of the little observation of the whole pathology. What we have to do is we have to correct these deformity forces, also in the moment that we make a revision of the prosthesis, because if not, it's not gonna be solved. And in this case, as you see here, we also underestimated many times in the last years, previous years, about the syndesmosis and all of these problems that comes from our evaluation of the post-traumatic patients, that they come with this undergoing diagnosis or treatment. We have to make this stabilization and once again, looking for the forces of deformation. Also, we are faced to aseptic loosening, as we saw in the statistics. What about this? But you see, sometimes it has to be with the design. We have to be aware of that, micro motions. And you see here, it doesn't work. We see here the contact and the loss of bone here. We have to check it, and maybe a design, when you see one of the pecs is really in contact with the wall and the other one is not, what it creates an imbalance that is making a micro motion, rotation, because it's not stable, once more, the contact, so we have to face it. Or the other possibility, and it is very ugly because we see these images that it's an overgrowing here in the pecs up. It's beginning the loss of the bone. There are holes. We have to take everything and see and reposition the quality of the bone. For that, we have to make a revision of the implants, and of course, we have to check what is the underlying causes. We repeat it so many times, the underlying cause. What it means that we didn't make a good planning or good evolution of the deformity forces of this pathology. You see, it's a big lost bone. Don't get stressed. There is always going to be a remaining good, strong, and quality bone that we can use to support our bone graft or whatever you decide to make it for your reconstruction, as we can see here. And once more, I have to tell you, at the beginning, I was like, this is scary. But then you begin to learn over the years how is the biology of a good bone when it is very balanced. And you see here, this is a very big problem, the subsidence. And you see instability and malalignment all together. It's never going to work. But the beginning of the problem is, once more, we didn't face the malalignment before we make the decision. You can make all the corrections, but when it is not well done, it will come. What happened with this subsidence is we have two possibilities. One is when the subtalar joint is not violated. And then you have maybe a better possibility to make or look for solutions. Like in this case, you see it's not taken, so you can solve it somehow. But here is a massive problem because you see that the subtalar joint is taken. So you must do something more, and maybe it is a bigger effort to look for solutions. But if you don't take this reconstruction where the position of the talus is going to be, you are not facing the real problem. So you will come back with everything. So in these cases, we have many possibilities. We have some cases with treatment, implant, or the TTC fusion, but we can also make what you see here is a customized situation, and it helps me because this component is gonna adapt to the bone loss, and it also will work with the whole mechanics of the prosthesis. But you see, we can never get a perfect situation, but very acceptable, looking for the other options that we have. And then we have this cyst formation. We have received many patients that come for a second opinion for this, the cyst. We get so nervous, surgeons, patients, and everybody, because we are so much touched to make an evolution of the X-ray. So how much power has the information of our radiologists in the hospital? There is a hole, there is something that is not going well. Even they should only describe the image, but they make so complicated it. And then we get scared. And this is an evolution, look at that. A cyst formation. We see at the beginning nothing, but then we begin to see this cyst formation. But we made pigs, we make cuts. So sometimes these cyst formations are full only of liquid that comes from the exudation of our own, procedure. Then if the patient normally don't have a pain, no symptoms, but they are scared, you can begin to be symptomatic when you see the picture. And that's a relationship that you have to have with your patient. Because if you see a hole, doctor, but maybe I will, no. So we have to keep calm and look at this evolution. Where is the cyst? It's gone. So wait and observe. Of course, if it is not complicated, and you will see that. If it is okay, it is okay. But you will tell me, yeah, but we have some cases that, come on, we cannot wait. If you have this hole, it's gone. And it's an evidence that something is going down, no? The talus is lost. So in these cases, again, have to learn not just to keep calm and to focus in the problem. We have a hole, it's like you have a fracture, you have to fix it. You have a hole, you have to fill it. So then you have to see how you make your revision and to be aware of all the material that you will need to fulfill. Once again, what is very important is that if you made a good evolution of your patient, you will see that the strength of the remaining bone sometimes help you. You see here how it is the position and the quality of the bone. Then you can face also the underlying problem, cause that is the syndesmotic problem. So then you fuse it and you replace it and you make this. And this is an example how it was solved. And we will check this because I know that it is one of the most questions that we have about the cyst. How we solve it? Normally, this is a case, we see the evolution, there is a conflicting problem, we see the bone loss, of course, there is evidence of this after 12 years. We have to make a revision, and in a CT scan, with a weight-bearing CT scan, we see that it is a huge hole. Nobody's going to tell us that it is going to disappear in 1 or 2 more years, and it is a long-term evolution. We have to make a revision, and we have a lot of options. What we always have in our table is good solutions like the graphing method, any one that you like, the components, and everything just to solve the cause and the whole. So after you have all your things, you go for the same approach, you check it, and voila, you have to take it, and you will find this. Normally, this kind of tissue. And this tissue is something that you have to be aware to take out and to make a good cleaning. It means this bag, that is a long-term bag, has to be taken out. If you want to solve it, you have to take this because it's a mixture of all these inflammatory cells and everything that will not allow you to make a good solution. So you have to take this back. But then it comes a very delicate moment when we are so excited about make a cleaning. Don't make too much. We just take the back. And then we see this is a bone that has a good quality. It's a bleeding bone. It's nice. then you have to stop. Stop, because I have seen many people trying to get accurate and make a cleaning. No, it's a good sign. We are in the right moment to make something more. So we use all we prepared before, our bone matrix. We make it impactation just to make a good contact with our bone graft, to make a good contact with a good bone that is remaining. Keep calm. And this is a technique we like to share tricks. When I first saw doing this, I said, how I didn't do it before. You just use your instrument and tap it. And because you made a good flattened area to receive this graft, it goes in one. Just whack, whack, and then it comes down. And you will see how is it in the position now. And then it begins the whole thing. You make a press with a laminar spreader. You have to use everything you have, and it gets a good lay for your component. You make all you learn to make that component. You make the holes. Sometimes you have to use also your own creative to adapt it, but this is the solution. The holes for the pegs are there, and then you use the same size, everything, always using this component matrix, because it also helps for the healing and helps also to you to sleep well. You made everything possible to get a good contact. And then you see here the compact impactation, because you have a good receptor area, and the sealing. It means that in the borders, you have always to put your little grafts to make it safe and stable. And after...
Excuse me, how do you handle the post-op follow-up of this patient, for example, with this big graft?
The follow-up.
The follow-up,
Yeah,
yes.
you have to be a little more cautious with a full weight bearing. We use it, as always, our 2 or 3 months with partial, but active. Yes, and immediately the charge is important, because...
May I just add something to this? A progressive cyst that comes overnight, that is progressive, and the reaction biologically, a response of the bone is the stress adaptation, and you see that this bone adapts to the remaining component. And most of these components are not loose. They are not pain when you take them out. So as Roxa showed, take out this membrane, you have bleeding bone, never touch this construct that's left, because that's so strong. And we use, you saw it there, use exactly the same implant. A new one, but the same implant, same position. That means we use the construct with the stress that was built up by the nature, and put that on, and we have shows the cavity. And that's very important. Of course, if you feel afterwards, we will be cautious with full weight bearing in the beginning.
That was the question, just to keep a little cautious.
Think about this, that it's very important. Just when you just come and cut it down or grab it and destroy what the nature has made, then you're lost.
And that is important, because as you saw when we took out the membrane, the whole status was almost the same as before, as the initial pathology. So all the soft tissue around, as he said, is also adapted. And don't take it out, because then you will change all the biomechanics that was learned. Did you see the case was after 12 years? It means a 12-year undergoing in an adaptation of the whole system. Just replace what is bad. That's it. And you see here, after 19 years of the initial prosthesis, it's going well. And you always have to face what you did. We were analyzing this case because for making our paper, sometimes you see your charts, and there is a little mistake here. And somebody's going to say, yeah, you feel, who wants to be bad with me will say, yeah, you feel the hole, but you missed something. What was missed here?
Not aligned ankle.
It's not a... Look at this. It's a good solution. We are happy, the happy patient. But for our own evolution, look, it moves. The syndesmosis, in those days we were not so focused, because we began to study more and publish more about our results with and these are the cases that gave us the ground to begin to study more about the effect of the syndesmosis. When you were asking me how, in what moment, you cannot do it with a short-term evolution. We are happy to have this long-term data also that allows us to see in the charts every case and every evolution. See, we are lucky, maybe the patient is so old enough that it was so bad that he has a solution, but we know now that it's gonna maybe fail or not, but that is. So always please analyze all the things that were the possible cause of these problems.
Just say that when you see the papers of Bonner, the French guy who reported all about his RAS ankle that has huge cyst formation, he used other technique, he made exactly the same, but he grabbed everything and put cement in. And he's saying that this is the only way to go. And there was a lot of controversy when we started with this technique with this. And we have some few cases we added a little bit a plump. Sometimes when in posterior aspect it's not strong enough, particularly in the anterior aspect, sometimes it's not strong enough. We put a little plump, but do the same. We don't like to fill the whole cyst with cement because that's a huge aggressive. We don't know what happened afterwards. But so we did some hybrid solutions.
Yeah, we always say, as I learn and we learn it, there is always time to make an arthrodesis. There is always time to put cement. But that's, as much as you can make a solution with biological things, you should try it.
Sorry, but for first replacement is changing indication. So when you read indication, you said you need at least 50% of the entire body well to put the prosthesis. And here you don't have that space. You have less than 50%. You're putting something creating bone there with a draft in the indication. No. I'm thinking about the first indications. When you read indications for total.
The papers. They say that if you want to.
At least 50%. And here you have less than 50%, and it's a revision. So.
Yeah.
It's changing everything.
Changing a lot, but yeah, okay.
Again, we have. This is not a normal talus. This is a construct like we put a house on poles. This is very strong and keep them. It's not a normal. That was a vascular necrosis. What we said in the beginning, we said more or less 50% we accept as the limit, to be the limit in vascular necrosis. But our surrounding bone is not built up stronger. And so I think it's not the same problems. And we do not have the answer. We published a paper about this, and we saw that up to 70% of bone loss on the surface with this technique that works.
Maybe we can talk also about that in another meeting, but I don't know if you agree, but look, when we have the loss of the talus also, so big portion, you still have another force, the subtalar joint. The subtalar joint gives you the possibility to work and make a whole holding with the hind foot. And that gives you the cement that every house needs to have a good bone stock coming from down to receive your talus. And you know, we are talking about this sandwich bone that allowed us to make the movements and to avoid all the peritalar instability. So we are in the way to look for these solutions, but that is one explanation that we can give you. So looking for the implant failures, as you see here, the insert has to be changed. But of course, once more, we see the alignment. The alignment is not good. So that was the problem. And the failure of the implant is because the alignment was not allowing to have a good position, the overloading of the burn. So, and we come back to this, to the syndesmotic instability. That is a new issue, and we are working a lot about this to prove that it is one of the main issues now to evaluate. As you see your own cases, you can make your own story. In this case, we revise it, we check, we change the insert, and we take out the instability from the syndesmosis, we fuse it like that, and with that, we gain our stable situation. And you see, after 5 years, it's a good evolution. So the stiffness, this is one of the worst situations for us because many people feel that A joint replacement is just to give a lot of motion on. And you see here, even that is so-called anatomic prosthesis. You see the bone growing in front? It's a huge limitation. So this is something that we still have to look more about this. We have to check, we have to study. Sometimes we forget to talk about the biologic problem of the patient. Maybe the patient has a ground that we have to check. We just have to face it, make a debridement as we saw, and revise it. Most of complications appear to be minor and do not affect the final clinical outcome. The periprosthetic deep joint infection can be a devastating and costly complication of arthroplasty. You have to face it and you have to solve it. And you are in your hands, you have to see what is the best solution to go with. Loosening and osteolysis are the most common reasons for failure in the TAR. In the papers we saw, periprosthetic bone cyst can, but must not, result in persistent pain and periprosthetic fracture. What I will put behind is learn to keep calm and just face it and look for the right solution. Most complications can be managed with adequate treatment measures. That is the most important thing, to know the tools that we can use. These are some of the subjects that we have put in the book that maybe can help you to see for many cases and the wonderful data from that, from many years. I think that we have finished with a summary thank you for your attention. Thank you so much for trying to focus in all this history, and maybe that can have given you some tools or some things to think about and look for solutions in your own cases.
Thank you, Roxa. So we think we have stressed or raised many questions. Maybe there's something we have to discuss now, or we will be able to discuss in the groups when we do the surgeries in the lab. So if anyone questions to that, what we told you, or other questions? Otherwise, I would suggest that we make a little break and start then to work in the lab.
Is okay?
Okay.
Okay. So thank you.
Thank you.